Hi, this is Dr. Gardner from Nicholls State University, and I will be lecturing on drugs affecting the cardiovascular and renal systems, Part 1 for Nursing 517. So we're going to learn about the pharmacodynamics and the pharmacokinetics. You'll be able to describe the mechanisms of action, absorption, distribution, metabolism, and excretion of different drugs that affect the cardiovascular and renal systems, including how those medications interact with the physiological processes that produce therapeutic effects. Also, we're going to talk about clinical pharmacotherapeutics. So you'll be able to discuss practical application of some of these cardiovascular and renal medications in clinical practice. So you need to understand this to prescribe, correct? Including picking the right drug, how are you going to dose the medication, how are you going to monitor, what kind of parameters are you going to use, how are you going to educate your patients, and then how are you going to manage any adverse effects? You want to be able to optimize patient outcomes. Let me go backwards. Let's see if I can go backwards a slide. Okay, so we're going to start off with angiotensin converting enzyme inhibitors. You guys may know that as an ACE inhibitor. So that's an angiotensin converting enzyme inhibitor or an ACE inhibitor. So how do those work? ACE inhibitors, that's like one of the main medications in cardiovascular pharmacotherapy. While they're not good for all populations, they're very, very good for some. And what these medicines do is they block the activity of ACEs. So it catalyzes the conversion of angiotensin 1 to angiotensin 2. And that's a very potent vasoconstrictor. So by inhibiting this conversion, the angiotensin converting enzyme inhibitors produce several benefits. It decreases the production of both angiotensin 2 and aldosterone. There's a reduction in vascular resistance without compromising the cardiac output and the GFR, or the glomerular filtration rate. And there's an enhanced breakdown of bradykinin. That is a vasodilatory peptide. So pretty much it blocks the ACE or prevents the conversion of angiotensin 1. It helps with vasodilation, relaxing those smooth muscles. So why is this clinically significant? Because that unique mechanism allows the ACE inhibitors to break down lower blood pressure while preserving vital organ perfusion. And it makes them really valuable for patients who have heart failure and those with renal disease. The renin angiotensin aldosterone system, understanding that it's essential for comprehending how ACE inhibitors and related medications work. This complex hormonal cascade plays a critical role in blood pressure regulation. It's important for fluid balance and for electrolyte homeostasis. The renin-angiotensin-aldosterone system, that begins when the kidneys release renin in response to decreased blood pressure or sodium levels. Renin then converts to angiotensin. It converts angiotensin to angiotensin 1, which is then converted to angiotensin 2 by ACE. Angiotensin 2, that causes vasoconstriction and stimulates aldosterone release. That causes sodium and water retention. So that system is a primary target for cardiovascular medications. ACE inhibitors have some other benefits as well, like cardiovascular and cerebral vascular protection. They provide comprehensive cardiovascular risk reduction beyond just blood pressure control. ACEs are indicated for heart failure management, and it has been shown that they can slow progression of renal disease, especially in diabetic patients. So you may see some of your diabetic patients on a very, very low dose of an ACE, and that is for its renal protective properties. So remember that ACEs are indicated for heart failure management, and they've been shown to slow the progression of renal disease, especially in diabetic patients. They're also used for cardiac remodeling prevention. They increase oxygen delivery to the heart muscle and prevent any inappropriate remodeling of cardiac tissue following a heart attack or in the setting of heart failure. This protective effect helps to maintain cardiac function over time. Advantages too. Unlike some of the other blood pressure medications, ACE inhibitors actually increase insulin sensitivity, and they don't adversely affect glucose metabolism or raise blood lipid levels. Makes them really suitable for patients with diabetes or metabolic syndrome. So this would be a good choice if the patient can tolerate it, if they have diabetes or metabolic syndrome. But they have to tolerate it. I think I've talked to you guys about those. The cough, remember that cough we've been talking about? If you get a patient with a cough that's taking an ACE, that trumps the diabetes or metabolic syndrome because you're not going to give that to your patient. Some clinical considerations and safety, of course. I talk about that dry cough. That dry cough, you guys. The bradykinin mediated, it occurs in about 5 to 20% of patients. And you're like, why does she talk about it so much? It's only 5 to 20% of patients. You'll be surprised when you're in clinic and you're prescribing what 20% of patients looks like. So, some absolute contraindications for an ACE. If they're pregnant, it's a no go. No way, no how. There's no benefit. You are not going to prescribe an ACE inhibitor to somebody who's pregnant. Why? Because of the teratogenic effect on the fetus. If they have a history of angioedema, oh, no way, you are not. Not at all. There is no risk versus benefit. It's a no, people. It's a no. And this happens more often in your Black and Asian patients. So if they have a history of angioedema, which you need to be getting the history, you are not by any means, going to give them an ACE inhibitor. If they have bilateral renal artery stenosis, that can cause acute renal failure. So we're not going to give them an ACE inhibitor. So then you're going to be very careful for patients who have hyperkalemia, if they have any problems with their liver, if they have a problem with hypovolemia or volume depletion, if they have renal failure or impairment, then we're gonna be careful. Okay, some adverse drug reactions. That dry cough, you guys will never forget. Loss of taste, that's temporary. So that's something, they may lose their taste, but that's something that's only temporary, so you don't have to stop their medication. Hypotension, especially with the first dose. Let me tell you, they've been walking around with this blood pressure that's through the roof for ages. Then all of a sudden they take an ACE inhibitor and their blood pressure bottoms. It can be expected, it can happen. So you want to educate them to be very careful when they take that first dose of medication. And then they're walking around with a much better blood pressure. So of course they think they're sick as their body is adjusting to having a normal blood pressure. They may have some blood dyscrasias. It's rare but serious. hyperkalemia. So we want to make sure we are monitoring their serum potassium levels. So what kind of monitoring is this? Do you guys remember? Is this active monitoring or passive monitoring? Um, Acute renal failure, there is a risk of bilateral stenosis. There is a risk of jaundice and pancreatitis and rash. Uncommon, but it can happen. If they get that cholestatic jaundice, then you're going to stop the medication. So, what do we use ACEs for? We use them for, of course, hypertension. It is one of the drug of choices for young patients. White populations and those with diabetes, heart failure, or after a heart attack, very, very good. We use less as monotherapy in our Black patients. Why? Because of that risk of angioedema. That's the ones you'll see with the cough. Consider a thiazide in this population instead. Hypertensive proteinuria diabetes, so an ACE, can slow the progression of diabetic nephropathy. And it does that by reducing the intraglomerular pressure and proteinuria. So it's good in those patients. Also, in angina and ischemic heart disease, because it reduces the myocardial oxygen demand by decreasing the peripheral vascular resistance or the afterload and preload, improving the balance between oxygen supply and demand. Some common ACE inhibitors that we use in practice, you'll see one that probably one of the most common is lisinopril. You start that one off at 10 milligrams a day with a max dose of 80. Another that you'll see quite often is enalapril. That is 2.5 milligrams twice a day if they're taking a diuretic, and 5 milligrams twice a day if they're not, with a max of 40. You may see benazepril. That's 5 milligrams if they're on a diuretic and 10 if they're not, with a max of 80. And then there's captopril. That one's 25 milligrams and it can be given 2 to 3 times a day with a maximum of 450. So those are just some of the common, but let's think about patient compliance. When it requires multiple daily dosing, sometimes you may have trouble with your patients taking it. One of the advantages is it has a shorter half-life, whereas like lisinopril and enalapril, those are convenient because the patient only has to take it once a day. Ramipril, there's strong evidence with that one for cardiovascular risk reduction. Ramipril can be opened and sprinkled on food. So if your patient has trouble swallowing, maybe they can't get their medicines down, maybe they have an aversion when they're taking pills, Ramipril would be a good option. So when we talk about rational drug selection and monitoring for the ACEs, let's talk about short acting versus long acting. Short acting. How do you know it's short acting? Well, you're giving it more times a day, right? So it's not having that long half life. So like captopril, you have to dose it 2 to 3 times a day, but you can actually have rapid dose adjustments. So that's useful, like in an acute setting. You have long acting like lisinopril and the others that are only once a day. It improves patient adherence because they only have to take it once a day. And then it provides more consistent blood pressure control throughout a 24-hour period. Think about the cost, of course. Remember, generic formulations, of course, are going to be much cheaper. If your patient can afford it, they're probably going to take it. Think about your special populations, like if your patient can't swallow and you need something that you can use that you can open and sprinkle, like Ramipril. When you're going to monitor the patient, of course, you're going to check a baseline blood pressure, right? You've already been monitoring the blood pressure. You've already had 2 significantly elevated blood pressures. So now we know we have their baseline. We're starting them. So we have a baseline blood pressure. We want to know what their renal function is. So we're going to check labs, right? We're going to check their renal function and we're going to check electrolytes. While the patient is taking the medication, you're always going to monitor their weight, their fluid status, and you're going to check for any signs of edema. You're going to check blood urea nitrogen, you're going to check the BUN, creatinine, and potassium. Remember, we want to watch and monitor for hyperkalemia. You're going to check their white blood cell count, especially in the first 3 months. We are going to tell our patients, take the medication at the same time every day. If they do not, take it when they remember the dose. Don't double up on the dose, but take it at the same time every day. If you forgot, if you take it every morning at 10 o'clock, it's noon, you're like, oh my God, I didn't take my medicine. Okay, well, take it at noon. Also, you want to let them know if they get a persistent dry cough to let you know, do not act like that dry cough is not important. You want to make sure your patient understands if they get that persistent dry cough to let you know. They need to change positions slowly so they can avoid orthostatic hypotension. Do not take any supplements unless they speak to the provider first. And then lifestyle modifications. Never stop doing the diet changes, exercise, and weight management. There's no magic pill. The patient has to do some work. So we want them to continue those lifestyle modifications. Okay, let's talk about the angiotensin II receptor blockers. Those provide an alternative mechanism for interrupting the renin-angiotensin-aldosterone system, rather than preventing the formation of angiotensin II like an ACE does. ARBs block angiotensin II receptors in multiple target organs. In the kidney, there's reduced sodium retention and aldosterone secretion. In the brain, there's decreased sympathetic outflow. In the heart, prevention of cardiac hypertrophy and remodeling. In the arterial walls, there's direct vasodilation and reduced peripheral vascular resistance. Some of the advantages of ARBs is that they inhibit the RAS pathway and decrease peripheral vascular resistance, which is very much like the ACEs. They are effective in kidney disease until late stages, and they provide a benefit in heart failure. Not all ARBs provide the same degree of renal protection as ACE inhibitors. So let's talk about the pharmacokinetics and drug interactions. Losartan, that's the prototypical ARB. It undergoes extensive first-pass metabolism in the liver. That results in about 33% bioavailability of that medication. This metabolism actually produces an active metabolite that is more potent than the parent compound, and it has a longer half-life. Some critical drug interactions. Losartan levels can be significantly affected by drugs that influence the cytochrome P450, 3A4, and 2C9 enzymes. Some of the inducers, like rifampin, phenytoin, and barbiturates, those decrease losartan levels. And then you have inhibitors like lovastatin, Bactrim, fluconazole, fluvastatin, fluvoxamine, and sertraline. Those are inhibitors, so they increase losartan levels. So for my students that are mental health You need to know. So you're taking this course, you need to understand these medications and these critical drug interactions. So if you've given your patient sertraline and they are on losartan, you have to be careful because why? It can increase those losartan levels. So you are responsible to tell your patients. And those of you who have patients, you are also responsible. Whether your family practice or your mental health, you always need to let your patient know. Give a complete list of medications to both your family practice provider, your gynecologist, your mental health provider, any provider that they're seeing. They should always have a complete list of medications. Okay, you want to monitor blood pressure closely when you're starting or stopping any of these medications. So, some precautions and contraindications when a patient is taking an ARB, of course, it's contraindicated in pregnancy. Tetragenic effects in pregnancy. You have to be careful if the patient has renal artery stenosis. Definitely want to monitor patients with renal impairment. And there is a risk of hyperkalemia, so you're monitoring those labs, right? Some of the advantages that ARBs do not cause that bradykinin-mediated dry cough, so this would be good in some of our African American patients that can't tolerate those ACE inhibitors. So, of course, this makes it a very good alternative for patients who can't tolerate an ACE. It is an alternative therapy for patients who are intolerant or resistant to ACE inhibitors. There is an enhanced effectiveness if you combine an ARB with like hydrochlorothiazide. It provides a good synergistic blood pressure reduction and it's convenient in combination products. However, we have to be careful because sometimes some insurances will not give them that combined product. They have to take two medicines. So they won't just give them the combination drug and then they have to take two pills. So we have to be careful of compliance. Typical starting doses would be losartan. You would start at about 50 milligrams once a day. If it's valsartan, they would take the 8160 once daily, and irbesartan is 150 milligrams once a day. Now you're going to monitor these patients similar to a patient taking an ACE. You're going to need a baseline and periodic renal function. You want to check their electrolytes, especially the potassium. Why? Because they have the risk of hyperkalemia. And of course, we're going to monitor their blood pressure. You're going to monitor for orthostatic hypotension, especially when you're changing a dose. Okay, so anytime you're changing a dose, you're going to continuously monitor this patient. You're not going to give this patient an ARB and say, go be in peace. That's it. I'm not seeing you anymore. Okay? You want to tell your patients about how to take this medication. You want to tell them about the potential for first dose hypotension, making sure they change their position slowly because we don't want them to get dizzy and pass out, right? And of course, a need for lifestyle modifications, restricting their sodium, weight reduction or weight management, and exercise. It doesn't go out the window when we start the medication. Some common ARBs that you may see, losartan, I've talked about that one, valsartan, telmisartan, irbesartan, candesartan, and esprosartan. So what's common? Think about what's common with the ACEs. Those are the prills, right? So think about the TANs for your ARBs. Those are the sartans, the TANs. Think about if you think about how am I going to remember this? I can remember the TANs, okay? So a clinical pearl to know is that while all ARBs block angiotensin II receptors, they differ in their duration of action, the dosing frequency, and the available combination products. Losartan and valsartan have the longest track records in clinical use. Some of the newer agents, like telmisartan, can offer a more consistent 24-hour blood pressure control. But again, those that are tried and true, we don't need to change them. We can use those. We know losartan and valsartan have a proven track record. Okay, direct renin inhibitors. So, a direct renin inhibitor represents the most upstream intervention in the RAS cascade. So, aliskiren is the only FDA-approved direct renin inhibitor. It directly blocks renin enzyme activity and it prevents the conversion of angiotensin to angiotensin 1, and it stops the cascade at the source. It is approved for the treatment of hypertension as a monotherapy or in combination with other antihypertensive agents. However, it is not indicated for heart failure, post-MI, or in diabetic patients who have reduced renal output. And that's due to the safety concerns that are identified in some trials. So this is just an as you know, probably won't see it on your exam, but you do need to understand this medication. Calcium channel blockers. What is the mechanism of action for calcium channel blockers? Well, they inhibit the influx of calcium ions through the voltage-gated calcium channels in cardiac and smooth muscle cells. That produces several therapeutic effects, like it reduces myocardial contractility, decreases the afterload, prolongs vascular smooth muscle relaxation, and it decreases transmembrane calcium content. Some of the classes, calcium channel blockers act 3 distinctive receptor types with unique properties. So, type 1, diltiazem or verapamil. They have negative chronotropic effects. Those slow the heart rate and conduction through the AV node. So they're very useful for rate control and atrial arrhythmias. You have type 2, like nifedipine and amlodipine. Those are primarily vascular effects with no significant effect on the AV node conduction. They may cause some reflex tachycardia with immediate release formulas. Okay. So when do we use a calcium channel blocker? They may reduce myocardial oxygen demand by decreasing afterload and contractility. There we go. So calcium channel blockers are preferred first-line agents for hypertension in Black patients who often have a different pathophysiology of hypertension with low renin levels. They provide effective blood pressure reduction across diverse populations. Good in our Black population. We use them for cardiac arrhythmias, like diltiazem and verapamil. They're very valuable in managing SVT and controlling ventricular rate and atrial fib due to their AV node blocking properties. Short-acting calcium channel blockers have more adverse effects like reflex tachycardia and hypotension. The extended release formulas provide a smoother, more controlled blood pressure control. With these, we're going to monitor liver function, baseline and periodically throughout treatment, heart rate and rhythm, right? That's important. Blood pressure, whether they're sitting and standing, we want to do both. We're going to check for peripheral edema and any signs of heart failure. Some things you're going to want to tell your patient is to take with meals if GI upset occurs, avoid grapefruit juice, including because it can increase drug levels, report dizziness, palpitations, or swelling, We want to tell the patient don't crush or chew extended release formulations and avoid alcohol and over-the-counter medications without talking to you first. So let's talk about digoxin. Digoxin is the classic positive inotrope. So pharmacodynamic actions of digoxin. Digoxin is a highly selective inhibitor of the sodium potassium or ATPase pump, one of the most important enzymes in cellular function. This inhibition leads to a cascade of effects. So there's increased intracellular sodium, increased intracellular calcium, and enhanced contractivity. The increased calcium availability strengthens myocardial contraction, and it has a positive inotropic effect. It also decreases the automaticity of pacemaker cells. It slows conduction velocity through the AV node. It lowers plasma norepinephrine levels. And it restores baroreceptor sensitivity in heart failure. It also reduces plasma renin activity. So these neurohormonal effects contribute significantly to symptom improvement in heart failure patients. So what is the effect on the sodium potassium pump? So if you understand digoxin's mechanism at the cellular level, then you can safely prescribe and recognize the potential toxicity of digoxin. The drug's therapeutic and toxic effects both stem from its inhibition of the sodium potassium ATP PACE pump. So, normal pump function. It normally maintains high potassium and low sodium inside the cells, creating the electrical gradient necessary for cellular function. Digoxin inhibition, it binds to inhibits the pump, causing sodium to accumulate intracellularly. The increased intracellular sodium drives calcium retention through the sodium-calcium exchanger, strengthening contractions. Digoxin is well absorbed from the GI tract. It has a bioavailability of about 60 to 80% for tablets and about 90 to 100% for any kind of oral solution. Peak serum levels occur 2 to 3 hours after oral administration. So the drug distributes extensively into tissues, particularly skeletal muscle. Unlike most cardiac drugs, digoxin is not extensively metabolized by the liver. Approximately 60 to 80% of it is excreted and unchanged by the kidneys, making renal function a critical consideration, right? You have to monitor the kidneys. The half-life is about 36 to 48 hours in patients with normal renal function, but that can extend over days for patients who have renal failure. So you got to be really, really careful. So some steady state considerations. In the absence of a loading dose, steady state digoxin levels are achieved after 4 half-lives, which typically equals approximately 1 week in patients with a normal kidney function. And of course, delayed onset is why loading doses are sometimes used in acute situations. Some medications significantly reduce the digoxin clearance. And if it does that, it increases the risk of toxicity. Medications like amiodarone, it increases digoxin levels by up to 100%. Verapamil and diltiazem increases digoxin levels by 50 to 75%. And then in quinidine, it doubles digoxin levels by decreasing renal and non-renal clearance. So if you're initiating these drugs in patients on digoxin, reduce the digoxin dose by about 50% and monitor those levels closely. Now, am I going to ask you this on an exam? Unless you're working at CIS, you are not going to do this in primary care. It's good to know. You need to know about it, but you're not going to be starting these patients on this digoxin. But this is good information to know. Because your patients are going to come to you on digoxin. But unless you're working with a specialist, you will not be doing this. Now, you do need to know the side effects, right? Like some of the common adverse reactions, um, anorexia or nausea. They may have vomiting and diarrhea. They may have some stomach discomfort. Signs of digoxin toxicity. If your patient is confused or disoriented, having some yellow-green vision and halos around lights, those are classic signs. In severe cases they may be hallucinating. You're gonna monitor their heart rate, and I know you guys know this. Everybody, you're gonna check for bradycardia, right? If their heart rate is less than 60, that's a problem on digoxin, right? If they're having PVCs, maybe there's an AV block, ventricular tachycardia. You may see that in children. Almost any arrhythmia can be caused by digoxin toxicity, so you're going to be checking digoxin levels. However, this is not something you're going to be doing as much in primary care, but some of you may choose to work with a cardiovascular specialist. So this is going to be important to know. But you do need to know signs of digoxin toxicity because your patient may come in with signs of digoxin toxicity. So you do need to know that. You use with extreme caution for those who have renal impairment. We talked about that. Dose adjustment is going to be needed. Electrolyte imbalances, especially if they have hypokalemia or hypomagnesia. Elderly patients, of course, because they may have a reduced clearance. And in patients with an acute MI. So when are we going to use digoxin? So you may have a patient with AFib because digoxin slows that ventricular response rate. You may see it for patients who have PSVT. You may see it in patients with heart failure with a reduced ejection fraction because it improves symptoms and reduces hospitalizations, but it's not reducing mortality. It is really reserved for patients who remain symptomatic despite optimal therapy with ACE inhibitors, beta blockers, and diuretics if they have heart failure. Assess for signs and symptoms of toxicity at every visit. Monitor their heart rate and rhythm. You're going to evaluate for improvement in heart failure symptoms like reduced dyspnea, edema, and exercise tolerance. Lab monitoring. The therapeutic range is 0.5 to 2, with a target of 0.5 to 0.9 for heart failure. Toxicity usually occurs at levels greater than 2, but it can occur at therapeutic levels with hypokalemia. So you're monitoring the potassium, magnesium, and calcium levels regularly, right? Also, you're checking their renal function periodically because clearance depends on their kidney function. So think about the labs you are going to check for. So when you're educating your patient, make sure you tell the patient take it at the same time every day. They should check their pulse before every dose. They should hold that dose and call you if their heart rate is less than 60 or greater than 100. Also, don't just tell them monitor for toxicity. They don't know what that means. Tell them, hey, let me know if you're nauseated, if you're vomiting, if you lose your appetite, not just for a couple days, but you don't have an appetite. Let me know if you have any yellow-green tint or those halos. Family, let me know if she gets confused, any unusual fatigue. I need to know that right away. Also, they should maintain consistent potassium intake. Tell them do not take any over-the-counter medications without approval. They can talk to you about their over-the-counter medications. They can speak to the pharmacist about their over-the-counter medications, but they need to know, do not just start taking stuff over the counter. And to let you know if they get any other new medications that are prescribed by anybody else, they need to let you know. So, let's talk about the mechanism of some antiarrhythmia medications. Class 1 is the sodium channel blockade. Block fast sodium channels, slow depolarization, reduces conduction velocity. Then there's the class 2, the beta blockade, that blocks sympathetic nervous system effects on the heart, reducing the heart rate and contractility. Then there's class 4, the calcium channel blockade, blocks the calcium influx and reduces contractility. Class 3 is potassium channel blockade that prolongs the effective refractory period and action potential duration. It reduces automaticity and ventricular ectopy. Ectopy. I do pronounce words wrong sometimes, guys. I'm a human. So we'll talk about class 1, which is sodium channel blockers. That's like your quinidine, procainamide, prolongs the QT interval, used for atrial and ventricular arrhythmias. Class 1B, which is like lidocaine, it shortens the duration of the action potential. It has minimal effect on the QT interval and is primarily used for ventricular arrhythmias. Class 1C, we don't use those as often. Those minimally increase action potential, most potent sodium channel blockade. And that's reserved for life-threatening arrhythmias. You guys are not going to be giving those out. Class 2, beta blockers. That reduces adrenergic activity in the heart by blocking beta adrenergic receptors. Some beta 1 selective drugs, metoprolol, atenolol. Class 3, potassium channel blockers, amiodarone. You see that one, right? That's one should be, you guys should know that one. These effects decrease automaticity of ventricular ectopy and help maintain normal sinus rhythm. Class 4, your calcium channel blockers. We've talked about those, right? Diltiazem, verapamil. Those block calcium influx into cardiac cells. They reduce afterload but have minimal effect on preload. So this is just a little clinical pearl. Amiodarone has properties of all 4 classes, but is classified as a class 3 because it has a predominant effect of prolonging action potential duration. Okay, so your beta blockers are the propranolol, metoprolol, sotalol. Those laws, listen to those words. Agents that prolong the duration of action potential, like potassium channel blockers and amiodarone, calcium channel blockers, verapamil, diltiazem, and then the sodium channel blockers, lidocaine, quinidine, procainamide. Think about the ones you know. Some considerations. We're going to use them with caution in patients who have cardiac conditions that can't tolerate an increased heart rate. This is probably, again, you need to know it, but unless you're working in a specialty area, you probably will not be the first prescriber of these medications. Caution in heart failure due to negative inotropic effects. Some common adverse effects of these medications, hypotension, right? Hypotension, orthostatic, and supine. They may feel dizzy, they may feel lightheaded, they may even have some syncope, especially with those that prolong the QT interval. May have some nausea, vomiting, constipation, fatigue, and exercise intolerance. Be careful with drug interactions. Always, 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 always know your patient's drug list. If they're taking Coumadin, that many antiarrhythmics enhance anticoagulant effects, requiring they should have an INR and monitoring much more frequently. Some other cardiac drugs, they have additive effects with other medications that can affect their heart rate, conduction, and contractility. So you need to know, what is your patient taking? So we're going to do a risk-benefit analysis for selection. The decision to use an antiarrhythmic usually requires careful consideration. And again, you probably will not be the one who's starting this antiarrhythmic, but you do need to understand what kind of monitoring, how the patient should be educated, and you need to understand the medications. So, lab electrolytes, especially potassium and magnesium. You're checking for renal and hepatic function and drug levels when you need to. An ECG, baseline, of course, and periodic monitoring for the QT interval. And then some electrophysiological studies for complex cases. So again, a lot of this will be done in a specialty clinic. But you want to tell your patient, don't ever just stop taking the medication. They may have rebound arrhythmias. They need to know to report any dizziness, any syncope, any palpitations. They should be checking, they should be checking their heart rate and their blood pressure regularly. They should keep all of their scheduled follow-up appointments with primary care and with cardio. Avoid caffeine and stimulants. They should limit their alcohol consumption. Manage their stress. Continue to exercise. Maintain healthy weight. Maintain good sleep patterns. Okay, we're gonna move on to nitrates. If you guys want to take a break, this is a good place to pause, take a break, stand up, take some deep breaths, because we're halfway through. Yes, this is quite long. This is long, but you can take a break. That's the beauty of a recording. You can stop it, take a break, and come back. Okay, we're going to get started with nitrates. Nitrates is good for vasodilation when patients are complaining of angina. They're potent vasodilators that work through a unique mechanism involving nitric oxide. When it's administered, nitrates are converted to nitric oxide in the vascular smooth muscle, and that leads to an activation of the GMP. So, venous dilation is predominant. It reduces venous return to the heart and it decreases the preload. At a higher dose, it can cause arteriodilation, which decreases systemic arterial pressure and decreases afterload. Or coronary vasodilation, which increases myocardial oxygen supply. Some of the hemodynamic benefits is that when it's combined, the combined effects of nitrates results in favorable changes in the myocardial oxygen supply demand balance. So there's a reduced preload decreases ventricular wall tension, and decreased afterload reduces the work of contraction. Different routes, of course, a sublingual route. If it's administered sublingually, it bypasses that first pass hepatic metabolism and it achieves rapid blood levels within 1 to 3 minutes. This route is the preferred route if they have acute angina. Make sure the patient understands to store those tablets in the original container and protect it from light and moisture. So no, they can't take them out and put them on their bedside table just in case they wake up during the night and have chest pain. That's a horrible idea. If they tell you they're doing that, tell them to stop. Keep it in its container, original container, and protect it from light and moisture. Don't take those little pills out and sit them on the bedside just in case you need them. That's a no-no. Oral route. Some isosorbide dinitrate, isosorbide mononitrate. Those undergo significant hepatic first pass effect, so that reduces the bioavailability of it. But these medications provide a longer duration of action, and those we use for prophylaxis. They have extended release formulas, and that makes it very easy for one's daily dosing. Then you have the transdermal route. If you've ever put it on, you have to put gloves on because why? If you don't have on gloves and it gets on your fingertips, you can get a headache by just fixing the medication. So we let the patients know about those headaches. But transdermal route, those are the nitroglycerin patches and they provide sustained drug delivery through the skin. It offers about 12 to 14 hours of a therapeutic effect, but it has to be removed to prevent tolerance. So you put that on a non-hairy part, make sure the skin is intact, and make sure they're rotating the sites. Okay. So let's talk about some of the contraindications. Nitrates are contraindicated for severe patients with severe anemia. If they're using phosphodiesterase inhibitors like Viagra, that is an absolute contraindication. Viagra, Cialis, all of those medicines. So explain to your patient why they have to be truthful. It is an absolute contraindication if they're taking that because they can have a life-threatening hypotension. Life-threatening. So they need to let you know. Or hypertrophic cardiomyopathy. You can't have a nitrate. So you can't take nitrates if you have a severe anemia. You can't be on nitrates if you have any of those Viagra, Cialis, any of the other ones, or if you have hypertrophic cardiomyopathy. Some relative contraindications or cautions, pregnancy. So this is the category C. We really don't use those, so you have to weigh the risk versus the benefits. Hypotension and hypovolemia, closed angle glaucoma because the nitrates may increase intraocular pressure. Also, if they have head trauma or cerebral hemorrhage. Some adverse drug reactions, headache, that's one of the most common. But it usually improves with continued use. But you're going to tell your patient, a headache is something that they may experience. Even to people who are administering the medication, if it's the transdermal and then they get it on their fingers, they may get a headache. Orthostatic hypertension and dizziness, syncope, especially with that first dose, and then reflex tachycardia. They may experience nausea, vomiting. They may have some flushing. Incontinence, although rare, can happen. Contact dermatitis with the patches because that's on their skin, right? Tolerance is a critical consideration. So start low, go slow. Use an eccentric dosing schedule, like doses at 8 a.m. and 2 p.m., not 8 and 8. So, you can't do that. 8 and 2. Provide a nitrate-free interval of 10 to 12 hours, typically overnight, so they don't develop a tolerance. Again, with erectile dysfunction drugs, that can cause severely, potentially fatal hypotension. So patient must wait at least 24 hours after the last nitrate dose. Antihypertensives, it can cause an additive hypotensive effect with all blood pressure medications, so you have to monitor them carefully. With aspirin, it can increase nitrate serum concentrations and enhance the effects. And with heparin, nitrates decrease the anticoagulant effect of heparin, so you have to watch their PTT closely. We use this for acute angina. Sublingual is the gold standard for acute anginal episodes. They're going to get relief within 1 to 5 minutes. You're going to dose 0.4 to 0.6 milligrams. Typically, it's 1 tablet or 1 spray under the tongue every 5 minutes, up to 3 doses. If chest pain persists after 3 doses, they need to seek emergency medical care immediately because they may be having a myocardial infarction. So that's a part of your education. Long-acting nitrates, remember these are used as prophylactics, so they have the isosorbide dinitrate. That's an immediate release formula, anywhere from 10 to 40 milligrams. They can take that 2 to 3 times daily. Sustained release is only once a day, and that's anywhere from 40 to 80 milligrams. The isosorbide mononitrate, that's 20 milligrams twice a day. usually at like 8 and 3, so they can have that nitrate-free interval, or they can have an extended release that's anywhere from 30 to 100 milligrams once a day. So tolerance develops less frequently with twice daily dosing, so keep that in mind. Think about if they need sublingual or translingual spray, that's for acute episodes. Transdermal is convenient, but it requires patch-free intervals. And then oral for long-term prevention or prophylaxis, so remember that. Patients need to be educated on sublingual to sit or lie down before taking it to prevent falls from hypotension. Long acting is going to require a 10 to 12 hour nitrate free interval. Don't crush or chew sustained release forms. Remember to tell them to keep those sublingual nitroglycerin tablets in the original brown bottle, protected from light and moisture, and they should be replacing that every 6 months. So tell them that they should experience a tingling under their tongue. That lets them know the tablet is active. If they put that in their mouth and there's nothing, that tablet is no longer activated. A good thing is to write the date on top of the bottle so they remember when they open it, because it will expire in 6 months. Some peripheral vasodilators like minoxidil, hydralazine, those are direct acting peripheral vasodilators that work through mechanisms that are distinct from other antihypertensive classes. They cause a direct relaxation and dilation of the arterial smooth muscle, thereby decreasing peripheral vascular resistance and lowering the blood pressure. Minoxidil is more potent than hydrazine, but it carries a greater risk of adverse effects like fluid retention and reflex tachycardia. It's typically reserved for the more severe resistant hypertension when all the other medications have failed. Key precautions: cardiovascular disease. Use with extreme caution in patients with coronary artery disease or if they've had an MI in the past. These drugs can worsen ischemia through reflex tachycardia and increase myocardial oxygen demand. And then with pulmonary hypertension, be careful. Be very careful, because peripheral vasodilation without proportional reduction in pulmonary pressures might worsen right heart function. So clinical management with hypertension, you'll see hydralazine starting at about 25 milligrams 4 times a day, increasing up to 100 milligrams 4 times a day. That's usually given with a beta blocker and a diuretic to minimize the adverse effects. Some of the drug reactions, they might have a headache, they may have water retention, reflux tachycardia, they may have increased cardiac contractility and output. With minoxidil, you may see hypertrichosis, that's a lot of hair growth, or they may have a pericardial effusion. Tell your patients, take it with food to enhance the absorption. They need to let you know if they have palpitations, if they have a rapid heart rate, if they're having unexplained fever, a lot of fatigue or joint pain. They should avoid NSAIDs and inform the providers about their medications. Everybody needs to know that they're taking it. And then, of course, continue with the non-pharmacologic interventions. Okay, understanding lipoproteins and cardiovascular risk. Uh, Atherosclerosis is a major cause of cardiovascular disease, including myocardial infarction, stroke, PVD. So, understanding lipid metabolism and its role is essential for prevention and treatment of cardiovascular disease. So, LDL, what is that? That's low density lipoprotein. That is not the happy one. Think about low. So that's the bad one, right? The primary atherogenic lipoprotein, it deposits cholesterol in the arterial walls. The target is less than 100 for most patients, less than 70 for high risk. Now, HDL, high density lipoprotein, that is the good cholesterol. Think happy. Happy, the good cholesterol. That removes cholesterol from the tissues and transports it to the liver. Higher levels are protective, so you want to see them have higher levels of HDL. In men, we want to see it over 40. In women, we want to see it over 50. You have your VLDL, which is the very low density lipoprotein. That is triglyceride rich lipoprotein, and it's produced by the liver. Elevated levels of VLDL contribute to arteriosclerosis and pancreatitis, so risk. And it's calculated as triglycerides divided by 5. Triglycerides, that's the fat molecules transported in lipoprotein. So think about fatty. Elevated levels increase the risk for cardiovascular issues and pancreatitis, especially when it's over 500. Target levels of triglyceride are less than 150. So let's talk about some of the anti-lipidemic drugs. So bile acid binding resins like cholestyramine, cholestyramine, those bind bile acids in the intestine, preventing reabsorption and forcing the liver to use cholesterol to make new bile acids. Ezetimibe, that blocks absorption at the intestinal brush border. And then omega-3 fatty acids and fibric acid derivatives enhance breakdown of triglyceride-rich lipoproteins. You have your HMG-CoA reductase inhibitors, or the statins, that block the rate-limiting step in hepatic cholesterol synthesis, causing an upregulation of LDL receptors and increased clearance of LDL from the blood, which is what we want to see, right? We want to get that LDL, the bad cholesterol, out. Sites of action for the anti-lipidemic drugs: bile acid sequestrants trap bile acids, while ezetimibe blocks cholesterol absorption at the intestinal brush border. And both of these reduce cholesterol entering the bloodstream from dietary sources. You have hepatic synthesis. Statins inhibit HMG-CoA reductase in the liver, the rate-limiting enzymes in cholesterol synthesis, and that forces the liver to upregulate LDL receptors to meet cholesterol needs. And then you have circulating lipoproteins, that's fibrates and omega-3 fatty acids, enhance lipoprotein lipase activity, increasing breakdown of triglyceride-rich particles. The PCSK9 inhibitors prevent LDL receptor degradation, increasing the LDL clearance. Now this may be a little bit hard for you to see, but you'll see it on your slide. Fibric acid derivatives like gemfibrozol or fenofibrate, those lower the triglyceride levels by about 30 to 50%, and they raise HDL about 10 to 20%, and there's a modest LDL reduction. So that's fibric acid derivatives, gemfibrozol, fenofibrate. Those dramatically lower triglycerides and raise HDL. And you usually see that for patients with hypertriglyceridemia, high triglycerides greater than 500, especially to prevent pancreatitis. So you also, it activates, well, you don't need to know that part. Okay, omega-3 carboxylic acids, that's prescription fish oil. And when they burp up the fish oil. Those lower triglycerides by anywhere from 20 to 50%, depending on the dose and the baseline level. You see that for patients with high triglycerides over 500. And there is a cardiovascular risk reduction. Bile acid sequestrants. like cholesterol, cholestyramine. The primary effect is to lower LDL cholesterol by about 15 to 30%, and it might increase triglycerides. Some of the advantage of your bile acid sequestrants, they're not systemically absorbed, safe in pregnancy and in children, and lowers glucose in type 2 diabetes. So bile acid sequestrants, that sounds really good, right? They lower the LDL, safe for pregnant women, safe for children, and might even lower glucose in diabetics. Your statins, your HMG-CoA reductase inhibitors, that's medicines like atorvastatin, rosuvastatin, simvastatin, pravastatin. Listen to all those statins. Those HMG-CoA reductase inhibitors are your statins. They lower LDL by 20 to 60%. They have modest effects on triglycerides and HDL. So the gold standard, most effective at reducing cardiovascular events, first line therapy for most patients that require lipid modification. And then you have your cholesterol absorption inhibitor, ezetimibe, that lowers the LDL by about 15 to 20% as monotherapy. Works good with statins, and then you'll see an additional 15 to 20% LDL reduction. The advantage is it's well tolerated, there's no myopathy risk, and it's an excellent option for statin intolerant patients or as an add-on therapy. Then you have your PCSK9 inhibitors. That is monoclonal antibodies administered subcutaneously. So they lower the LDL by about 50 to 70%. And it's the most potent LDL lowering agents available. Your PCSK9 are the most potent LDL lowering agents that are available. They're only indicated for very high risk patients, not at goal, no matter what you've done with your statins or with familial hypocholesterolemia, or if they have a statin intolerance. So these are not just the ones that you're going to go to first. So some pharmacokinetic considerations. With bile acid sequestrants, they're not absorbed at all. They work entirely in the GI tract. Ezetimibe is well absorbed. It undergoes enterohepatic recirculation. Statin, the absorption ranges from 30% to 50%. Low atorvastatin is at 50. Food decreases the rate of absorption of most reductase inhibitors, so though clinical significance is minimal. And then your PCSK9, they're administered sub-Q, and you'll achieve peak levels for those patients within 3 to 7 days. Some of the hepatic metabolism and CYP450 enzymes, like your high interaction risk CYP3A4 substrates, simvastatin, lovastatin, and atorvastatin. Most statins are extensively metabolized by the liver via the CYP450 enzyme systems, particularly CYP3A4 and CYP2C9. So that creates potential for significant drug interactions. There's a lower interaction risk with pravastatin, rosuvastatin, and pitavastatin. And then there's important exceptions like bile acid sequestrants and ezetimibe are not metabolized by the liver, making them safe options if the patient has liver disease. So you have to think about that, right? And then the half-life, it varies with these, and I'm not going to ask you the half-life on the test of these medications. That's a bit much. Okay, so let's think about the absolute contraindications for statin. If they're allergic to it, they can't have it. If they're pregnant or lactating, they're not going to have it, right? So we're not going to use anti-lipidemics for anybody who's pregnant or breastfeeding. If they have active liver disease, we're not going to use it. It's an absolute contraindication. We are going to be careful If they have a history of alcohol misuse, you want to monitor for drug-induced hepatitis. If there's any kind of medicine that affects statin metabolism, if they're older, frail, small body frame, um, if they have hypothyroidism, and then diabetes risk because statins can modestly increase blood glucose levels. So we want to also monitor when patients are diabetic. Some of the additional precautions for bile acid sequestration: fat-soluble volumin deficiency, hypertriglycerides, and a history of constipation or bowel obstruction. Some things that patients may complain about, if it's fenofibrates or gemfibrozil, they have an increased risk of gallstones, myopathy when combined with statins. They may complain of dyspepsia, abdominal pain, or diarrhea. With statins, they may complain of myalgia. Oh, my muscles ache. Oh, it hurts. And they may have that without an elevated CK. Headache, they may have it at the beginning, that will go away. They may complain of nausea, constipation, or gas. They may feel gassy. Rare, but it can happen where they can have rhabdomyolysis. You got to be very careful of that. Mild elevation in liver enzymes, so we're going to watch their liver, and that can happen in about 2 to 3% of the patients. And we want to monitor for diabetes. So for LDL, elevated LDL cholesterol, that's the bad cholesterol, right? First line, statins, rosuvastatin, Crestor. Crestor is like the Cadillac of the statins. Most potent of them. It starts at about 5 to 10 milligrams a day. Max is 40. Preferred for patients needing a dramatic LDL reduction, so greater than 50%. Atorvastatin or Lipitor is very potent with excellent adverse effects profile. Start about 10 to 20 daily and titrate up to 80. Long acting allows a flexible dosing time. Simvastatin or Zocor has a moderate potency. There is a generic available. There's generic for all of these. There's rosuvastatin, atorvastatin, and simvastatin are all generic. For Zocor, you're not going to give them more than 40 milligrams because they have an increased risk of myopathy. Then there's lovastatin. It's immediate release, 20 milligrams daily with the evening meal. Extended release is 40 to 60 milligrams at bedtime. So you can add ezetimibe 10 milligrams daily for an additional 15 to 20% LDL reduction. And then bile acid sequestrations, that's an alternative if they can't tolerate statin. For low HDL, you have options of fibric acid derivatives. Those are most effective at raising LDL. You'll see about a 10 to 20% increase. High potency statins like rosuvastatin, atorvastatin, and simvastatin, they provide a modest HDL increase. And then niacin, historically that was used, but concerns about the adverse effects and the questionable cardiovascular benefit, they're not used quite as much. Plus, patients used to complain about the flushing with niacin, so you don't really see that prescribed. The first thing patients should do is exercise, quit smoking, limit their alcohol intake, and lose weight. Those things alone can significantly raise the HDL. For elevated VLDL and triglycerides, we use the fibric acid derivatives like fenofibrate and gemfibrozil. Gemfibrozil is 600 milligrams twice a day. You take that 30 minutes before a meal. Avoid with statins due to the increased myopathy risk. Omega-3 fatty acids, there is Loveza. That's about 2 to 4 grams daily. That reduces triglycerides from anywhere from 14 to 30%. If they have very high triglycerides, greater than 500, they're going to need aggressive therapy to prevent them from getting pancreatitis. So consider giving them a fibrate and on omega-3 fatty acid, and they need to adhere to a strict low-fat diet. So no junky fatty foods, candies, things like that they need to avoid. To manage mixed dyslipidemia, first, assess the primary abnormality, determine which lipid fraction poses the greatest cardiovascular risk. In most cases, an elevated LDL is the primary target. Remember, LDL, low, that's the bad cholesterol. Step 2, start them on a statin. Of course, you're going to start lifestyle reductions, right? They need to lose weight, they need to exercise, they need to stop smoking, they need to limit their alcohol intake. Then you're going to initiate a statin. Start with the appropriate intensity statin based on their risk. So, statins provide the greatest mortality benefit and address both the LDL and moderately elevated triglycerides. Next, you're going to add a second agent. If the triglycerides stay elevated, greater than 200, or HDL is very low after you've gotten your statin where it needs to be, then consider adding a fibrate or an omega-3 fatty acid. Next, you're going to maximize therapy. If it's a very high-risk patient and they're not at goal, something like ezetimibe, or consider one of those PCSK9 inhibitors for further LDL reduction. First-line therapy depends on severity. Remember that. Triglycerides, 200 to 499. Statin therapy often suffices, but if their triglycerides are greater than 500, then you're going to need to give them a fibrate or a high-dose omega-3 therapy to reduce the pancreatitis risk. And you can add a statin once their triglycerides are less than 500. So, how are you going to pick what you're doing? And how are you going to monitor? If they're very high risk, they have established cardiovascular disease, they have diabetes, and they have some cardiovascular disease risk factors, or if they have acute coronary syndrome, you're going to use a high intensity statin, something like a torvastatin or rosuvastatin. High risk, if their LDL is greater than 190, if they're diabetic and they're anywhere between 40 to 75 years old, if they have a 10-year risk greater than 20%, moderate to high intensity statins. Moderate risk is a 10-year risk, 7.5 to 20%. Consider a high intensity. First line therapy is going to be lifestyle modification for all patients. All patients. You're going to tell them, what is lifestyle? You need to exercise, you need to lose weight, you need to stop smoking, limit your alcohol. That can reduce their LDL by 20 to 30%. So statins are first line in adults up to age 75. Evidence is less clear over 75 without established cardiovascular disease. Bile acid sequestrations are safe in children and adolescents with familiar hypocholesterolemia. Generic statins, of course, are going to be cheaper, so we're going to go with those first. Bile acid sequestrants, generic formulas are available and cost effective, but the GI side effects limit the tolerability. PCSK9 inhibitors, that cost about 5,000 to 14,000 annually and used only when other therapies have failed or are inadequate. That's not first line. So monotherapy versus combination therapy. Most patients can achieve lipid targets with just a statin alone. But high-risk patients may need a statin and ezetimibe. They may need a statin and a fibrate, or they may need a statin and a PCSK9. That's very, very high-risk patients. So monitoring baseline before you even start the statin. Get a fasting lipid level. Check their liver function tests, their AST and their ALT. Consider getting a CK if the patient has risk factors for myopathy. And you want to check a fasting glucose, or you can check a hemoglobin A1C. Early follow-up, 6 to 12 weeks. Check a lipid panel to see how they're responding to therapy. Check their liver, assess for symptoms of myopathy or any other adverse effects. And then ongoing, you will check their lipid panel annually, more frequently if they're not at goal. So don't think after the 6 to 12 weeks, okay, well, Dr. Garner said we just need to check it annually. That's only if they're at goal. But if they're not at goal, you're going to check them more frequently. Check their liver function test as clinically indicated, because that's not routine. Hemoglobin A1C periodically, and for your patients that are diabetic or those at risk, and do a clinical assessment for myalgia at every visit. You're going to educate your patients if they're on bile acid sequestrants. They have to take that before meals to bind bile acids. They mix the powder forms thoroughly with water or juice. Take other medications 1 hour before or 4 to 6 hours after to prevent binding. Statins are most of them are taken in the evening, and that's because it was believed that due to the circadian cholesterol synthesis, though timing flexibility exists for many. But it used to be like you would tell them to take it at night because you thought there was something going on with their synthesis during the night. They can be taken with or without food, except lovastatin, immediate release. Take that with the evening meal for better absorption. Atorvastatin and rosuvastatin can be taken any time of the day as long as it's taken consistently. Fibrates take 30 minutes before meals for best absorption, and then the PCSK9 inhibitors, that's a sub-Q injection every 2 weeks or monthly. And so you're going to have to teach your patient proper injection technique, how to rotate the sites, and how to store it, which would be in the refrigerator. Statins, we want to tell our patients about that myopathy. It's very important. Any unexplained muscle pain, tenderness, weakness, or fatigue immediately, especially if accompanied by fever or dark urine, because that's a sign of rhabdo, they need to let you know. Those symptoms can develop at any time, even after they've been taking this for years. So don't discount it because you think, oh, they've been on this too long. They can't have rhabdo. Yes, they can. Constipation management, especially for bile acid, increased fluid intake, increased dietary fiber, physical activity. They might need a stool softener or a laxative. If they have a headache, let them know that's usually transient with statin. They could use something over the counter like Tylenol or ibuprofen if they need it. Warning signs that require immediate medical attention: severe muscle pain, dark urine, yellowing of the skin or the eyes, because then they've got jaundice, right? Hopefully they don't wait that long to come and see you. Severe abdominal pain, especially with fibrates, because they may have a pancreatitis. Exercise. Tell your patients they need to aim for at least 150 minutes of moderate exercise every week. Regular exercise is going to raise that HDL and lower those triglycerides. They need to quit smoking. That's very important because that's going to smoking dramatically lowers the HDL and accelerates the plaques that they have. So give them resources, help them to quit smoking. They need to reduce their saturated fat, trans fat, and cholesterol. They need to increase their soluble fiber. Plant sterols, and a Mediterranean diet has been proven beneficial. Lose weight if needed. Even 5 to 10% of the body weight is going to help. That's going to significantly improve their livelihood, their longevity. It will improve their lipid profile, especially triglycerides. And then moderate intake of alcohol. 1 drink for women, 1 to 2 for men. And that says a day, but that's quite a lot, really. It may raise the HDL, but excessive intake also raises their triglycerides. Okay, we're going to talk a little bit about diuretics. Let's see. Diuretics do have a role in cardiovascular management. They represent a first-line pharmacotherapy for both heart failure and hypertension. They're effective, they're pretty safe, there's a low cost to make them indispensable. And so this helps to get rid of the sodium in water. So there's different types. There's thiazides and thiazide-like agents. Those inhibit sodium reabsorption in the distal convoluted tubule. They have moderate potency. You have potassium-sparing diuretics like aldosterone antagonists that block aldosterone receptors in the collecting duct. They're weak diuretics, but they prevent potassium loss. Potassium sparing prevents potassium loss. Okay, makes sense? Loop diuretics, those inhibit sodium potassium chloride, co-transporter in the thick ascending limb of the loop of Henle. They're their most potent diuretics available is the loop diuretics. They produce rapid, profound diureses. Loop diuretics maintain effectiveness even in renal impairment, while thiazides lose efficacy if the GFR is less than 30. Okay, so sites of diuretic action in the nephron. I'm not going to ask you this on your exam, but sites of action would be the glomerulus, the loop of Henle, the distal tubule, and the collecting duct. So diuretics promote sodium excretion. That leads to a decreased plasma volume and reduced cardiac output. That's short term. With chronic use, cardiac output returns toward normal, but peripheral vascular resistance remains decreased, resulting in a sustained blood pressure reduction. The absorption and distribution vary significantly among those. Loop diuretics are rapidly absorbed within 30 to 60 minutes oral, 5 minutes IV. Thiazides have a slower onset, about 1 to 2 hours, but they have a longer duration, about 12 to 24 hours. Most diuretics are metabolized in the liver and excreted in the urine. So there is some special consideration for diabetic nephropathy. So amiloride contraindication, potassium-sparing diuretics, particularly amiloride, are contraindicated in diabetic nephropathy due to increased risk of hyperkalemia. And diabetic patients often have hyponuremic hypoaldosteronism, and that impairs potassium excretion. So we have to be very careful. Some safety and adverse effects, electrolyte imbalances. All diuretics can cause electrolyte disturbances. Thiazide and loop diuretics cause hypokalemia, hyponatremia, hypomagnesia, and hypercalcemia. Thiazides or loops. Gout, thiazides and loop diuretics decrease uric acid and uric acid excretion, so it can actually make gout attacks worse, even in those with gout or without. Diabetes, so thiazides can impair glucose tolerance and worsen glycemic control. So you really need to weigh the risk versus benefit. It can cause excessive diuresis can cause symptomatic hypotension. So especially in elderly patients or those who are taking multiple antihypertensives. So think about some situations where a thiazide or a diuretic may cause a problem. Think about real world situations where you may see a diuretic causing a problem. I want you to put your thinking caps on for this. It may cause an electrolyte imbalance, like hypokalemia, thiazides, and loops. You may have a risk for arrhythmias and muscle weakness. You may see some hyponatremia. You may see some hyperkalemia with the potassium sparing or hypomagnesemia. Some critical drug interactions with lithium. A thiazide and a loop diuretic decreases renal lithium excretion, so that increases toxicity. So you have to monitor those lithium levels closely. With sulfonylureas and insulin, thiazides and loops may decrease hypoglycemic effects, requiring some dose adjustments. If they're using NSAIDs or salicylates, it may decrease the diuretic effectiveness for those. ACE inhibitors and potassium-sparing diuretics, that's a dangerous combination. It can cause a severe hyperkalemia. So if you must combine them, you have to monitor potassium closely, but that is a dangerous combination. So be very, very careful. So selecting the right agents, thiazides. Thiazides are first line for hypertension in most patients, but they do have the most adverse metabolic effects. So with diabetes, gout, Their advantages is a long duration of action. You can take it once a day. It improves the adherence, of course. Chlorthalidone is more potent and longer acting than hydrochlorothiazide, HCTZ. Chlorthalidone is old, but it's tried and true. It's good. With cardiac disorders, we want to prevent any complications. So, um, if you're using it with an ACE or an ARB, it could raise potassium. Add a potassium-sparing diuretic like spironolactone. Potassium supplementation, though less preferred than above options. Regular monitoring, of course, of potassium and magnesium. Okay, we are getting towards the end. Let's see. Um, Diuretics for hypertensive management. Thiazide type diuretics as a monotherapy, that's preferred initial therapy for most patients with uncomplicated hypertension. Um, you may see sodium sensitive populations like Black patients and the elderly, those over 65, some who have obesity related hypertension, or mild to moderate renal insufficiency, but you have to make sure you're picking the correct one. Some typical starting would be HCTZ at 12.5 to 25 milligrams daily. Chlorthalidone, which is really good. Remember, that one's more potent, longer acting. Chlorthalidone is great. Not used often enough. Excuse me. If it's for edema, like patients with heart failure, diuretics are essential for symptom relief, but they're used as an adjunct to disease-modifying therapy. ACE inhibitors, beta blockers, aldosterone, then you'll see these diuretics used. For mild heart failure, thiazides may suffice. If they have moderate to severe heart failure, you may see loops used instead. If they have a refractory edema, you may see a combination of a loop and a thiazide. The recommended diuretic agents for loops, you may see furosemide or torsemide. Furosemide is one that we've all seen often. It's anywhere from 20 to 80 milligrams daily or twice, but the dose is individualized. Thiazides, that's your HCTZ and your chlorthalidone. Remember, chlorthalidone has a longer half-life. It's more potent and you've got great outcomes. HCTZ, you see it used often. It's commonly prescribed, but it's less potent. Don't know why people don't use chlorthalidone more often. It's really a good drug. Potassium sparing would be spironolactone and eplerenone. So for diuretics, we are going to monitor prior to initiating therapy. You're going to get a CMP, you're going to get a bun and creatinine. Electrolytes, you want to check sodium, potassium, calcium, magnesium, and bicarb. You want to check their uric acid, especially if they have a risk for gout. And you want to check a fasting glucose. While the patient is on a diuretic, you're going to check their electrolytes 1 to 2 weeks after you start the medication or change a dose. And then you'll monitor every 3 to 6 months. More frequent monitoring in heart failure, those with renal impairment, or combined with other drugs. So when are you going to check their labs more frequently? If they're sick, like they have vomiting and diarrhea, if they've been on new medications, if you suspect an electrolyte imbalance, the elderly patients are at higher risk, or if you've recently increased their dose. If you're starting on an ACE or an ARB in a patient that has a potassium sparing diuretic, you're going to check their labs. You do want to educate your patient about taking it as directed, especially early in the day, because you don't want to stay up all night using the bathroom. They need to recognize if they're getting dehydrated or have any hypovolemia, like if they're really thirsty, if they're really dizzy, their urine is dark, they're not really producing urine, their heart rate is racing. If they have any muscle cramps or weakness, excessive fatigue or confusion, um, explain photosensitivity to them, tell them to use sunscreen, protective clothing, avoid tanning beds. They need to be checking their blood pressure, their heart rate. We're going to be monitoring for edema. And then we're going to be checking their jugular vein distension, especially for heart failure patients. Teach your patients to weigh themselves at the same time daily, ideally morning after going to the bathroom, but before eating, and in similar clothing. They need to let you know if they gain 2 to 3 pounds in one day or 5 pounds in 1 week. They need to be monitoring their blood pressure at home if it's prescribed for hypertension, and they need to keep a log of their weights and their blood pressures to share with you at their appointments. And dietary sodium should be limited to 2 to 3 grams daily if they have hypertension, 2 grams for heart failure. Talk to them about reading food labels, avoiding processed foods, and not adding salt to their food. If they're on a loop or a thiazide, include potassium-rich foods like bananas, oranges, potatoes, and spinach, unless they can't have it. Avoid salt substitutes because they contain potassium if on a potassium-sparing diuretic. Fluid intake is generally unrestricted unless they have heart failure. And then they need to limit their alcohol intake because that can worsen hypotension and their electrolyte imbalances. Okay, so this is just a quick summary before we do our knowledge check. Cardiovascular and renal pharmacology. So chronic disease management, there's drugs affecting the cardiovascular and renal systems, predominantly treat chronic lifelong conditions requiring long-term therapy and consistent patient adherence. We need to educate our patients, comprehensive patient teaching about when should they take the drug, what kind of side effects, how should they monitor, what about lifestyle modifications, empower them to participate actively in their care so they can improve their outcomes. Understand the mechanism of action, absorption, distribution, metabolism, and excretion of these medications. That's important for safe, effective prescribing and anticipating any kind of drug reactions or interactions. Know about clinical indications. When do you use it? What are you going to use a statin for? What are you going to use a diuretic for? What are you going to use a calcium channel blocker for? Patient monitoring. Know what labs to get and when. So knowing all of these is important as a prescriber. You have to know what you're prescribing for, what's the mechanism of action, how are you going to monitor, and how are you going to educate your patients. Okay, let's do a check on knowledge. Which class of drug can produce a persistent dry cough? Is it an angiotensin converting enzyme inhibitor? Is it a nitrate? Is it an angiotensin II receptor blocker? Or is it a cardiac glycoside? Which of the following drugs require a 10 to 12-hour drug-free period? Is it a calcium channel blocker, an omega-3 fatty acid, a nitrate, or a diuretic? Lab monitoring for patients on ACE inhibitors or ARBs include which of the following? A, white blood cell counts with drug dosage increase for elevations above 10,000. Liver function tests with drug dosage stop for alanine aminotransferase values twice that of normal. Serum creatinine levels with the drug dosage reduced for values greater than 2.5. Or serum glucose levels with the drug doses increased for levels greater than 120. Jacob has hypertension, for which a calcium channel blocker has been prescribed. This drug helps control blood pressure because it A, decreases the amount of calcium inside the arterial smooth muscle, B, reduces stroke volume, C, increases the activity of the sodium, potassium, ATP, ACE pump indirectly, or decreases heart rate. Question 5. A potentially life-threatening adverse response to an ACE inhibitor is angioedema. Which of the following statements is true about this adverse response? A. Swelling of the tongue and hoarseness are the most common symptoms. B. It appears to be related to the decrease in aldosterone production. C. Presence of a dry, hacking cough indicate a risk for this adverse response. Or D. Because it takes time to build up in the blood, it occurs after being on the drug for about 1 week. Okay, so that was a lot. That was a lot. So, how can you continue your learning? Review the material regularly. You'll be applying these in clinical practice when you get to your clinicals, but look for evidence-based resources when you're managing complex cases. Refer to the current clinical guidelines, pharmacology references, and prescribing information for the most up-to-date recommendations. Always consider the whole patient, comorbidities, concurrent medications, lifestyle factors, and individual goals. So that is it for this lecture.